Next, we have Dr. Laurel Copeland. Dr. Copeland is an expert in conducting research with large medical data sets. She trained at the University of Michigan School of Public Health and is the governing board representative for the Healthcare Systems Research Network for Baylor Scott and White Health. Among her current projects are the treatment of youth and nonprofit health programs and the experiences of mental health patients in the VA. Let me put this up. Thank you so much. And she gave up a bunch of meetings to come here today. So I'm really excited to hear what she's got to say.
You know how fun those are. Okay, I'm one of those nervous speakers. I'm not a clinician. I don't work with people, so just bear with me and get your pea shooter out and send me some Indrol, okay? All right. Yes, I'm Laurel Copeland. I'm with the Center for Applied Health Research up in Temple, Texas. And I work on both sides. I'm in the VA. I have a 6/8 appointment there working with the VA projects that I'll talk about today. I also have the appointment half-time at Baylor Scott and White that was mentioned. Disclosure, no conflicts of interest. There's a long list of funders, and most of them have to do with the very last project I'll tell you about, which was coordinated by the Henry Jackson Foundation for Military Advancement of Military Medicine. And if you ever get out there for their Heroes of Military Medicine dinner in May, it's amazing. The presentations and the science are just great. When I got into the VA, I was an unemployed English and French literature major. And I got a part-time job. I took a job as a research assistant doing field work for a survey project. I had an aptitude for the data programming part. I remember I said I wasn't really good with people. And so I eventually landed in the VA in 1996. And the first project I worked on was called the Long-Term Mental Health Project, which is run by the VA in Ann Arbor. In 1990, Congress got a Joint Commission report that said that veterans who had schizophrenia or other psychotic disorders were dying of untreated heart disease. And they said, why is this? And they funded the Serious Mental Illness Treatment Research and Evaluation Center, MITREC, to roll out some innovative programming for veterans with schizophrenia and to evaluate how those programs did. So the project enrolled 1,425 VA patients who were really psychotically ill. They had 5 or more hospitalizations for psychiatric reasons in the prior year, or 150 inpatient days for psychiatric issues in the prior year. And these veterans were primarily being treated in long-term mental health, in mental health inpatient facilities, because this was in the early 90s, and that's how things were in the VA back then. The project surveyed the patients and their providers every 6 to 12 months, and it ended up having 5 years of follow-up. I was hired in 1996, and the VA deinstitutionalized and adopted a managed care model in the period 95 to 97. So this is a very interesting time to do this research because we really needed new models of care. The short story on what the results were is that of the 3 programs the new programs that they trialed, 2 of them, partial hospitalization and community care management, were much better at helping the veterans control their symptoms and function in life. And that has replaced what was then standard outpatient care. Then I moved into more studies of chronic diseases because schizophrenia is a chronic disease. And in 2003, 2006, we studied inpatient deaths. And we looked at, when people come into the VA and they die, which does happen, what was the approximate cause of death, and what was their past year history of illnesses. And it turns out that, and you just sort of overall, there's about 8% of people who will come into the hospital and they don't really, have an obvious reason for why they dropped dead. And we called this unforeseen death because it was unforeseen, it was unexpected, and not, it wasn't a sudden death as in cardiac, it was just for some reason they died very quickly when they came in. But for patients with schizophrenia, this percentage was 20%, which was a huge uptick. And we looked at why this was. The critical factors turned out to be, A, schizophrenia per se, because it is a very destabilizing condition that's associated with unhealthy lifestyle, and B, lack of system contact for the previous 12 months. So we published an article, and central office read it and called me up, gave me a heart attack, hi, this is the Inspector General. Oh my God, what did I do? And really, they just wanted to talk about the research. They went on to do a pilot program that was run out of, again, SMyTrack in Ann Arbor, and it became a directive for outreach to veterans with psychotic illnesses. If they aren't seen in 12 months, you have to call them up and find them and bring them in, and that has helped reduce mortality for those patients. I continue to do preventive care on these patients. We looked at outpatient care, since now we're in a managed care environment, and it turns out that because patients with schizophrenia are on antipsychotics, they have a tendency to develop diabetes and to have weight gain and other metabolic disturbances. So it's important to monitor whether or not these patients are gaining weight, have elevated blood pressure, have bad lipid profiles, have sugar abnormalities, is their blood sugar rising. And it turns out that that was really rare for VA patients with schizophrenia back in the early 2000s. But if you did test for blood sugar problems, and you did treat it, they lived longer. So that was a good study to do. Then during this time, September 11th happened. I was in the VA during this time. A friend of mine was in the World Trade Center North Tower and died. And so I was very motivated to apply for a little funding that was available the year after that. And I did a survey 1 year later of veterans in two VAs, the one in Ann Arbor, because I was there, and the one in Lower Manhattan, which is the closest to the World Trade Center. And we asked about their PTSD symptoms and some other background factors. And the interesting thing was that the site was not the most important factor, which I had expected, but rather their background, especially their Hispanic cultural background, was positively associated with more PTSD symptoms. So I started to think a little bit more about other factors other than just physical illness being important predictors. So now I'm moving toward research on younger veterans. The veterans with schizophrenia were mostly Vietnam era or older, so they were older veterans. And OAF, we tend to think of, okay, these are people who came back from Iraq and Afghanistan. Actually, there's a very long list of regions and countries that you see there where you could be deployed, and then you would be categorized as OAF. And if that's not enough, here's a picture. So this is a very big arena of operations. And I actually had a colleague whose son was in the Navy at this time, and he kept saying, yeah, so we're going to, pass by Madrid or something. We're sailing towards Greece. And finally, she says, well, I'm really glad you're having a great time with it. And he says, Mom, by this time, most people have figured out where we really are. Yeah, he wasn't in Greece. But yes. So I started to study the OAF population. I did move down to San Antonio, which is a wonderful place for military medicine because of all the bases around there. And that ended up being important in some of the studies. Now, in terms of death, which, again, I was studying, the OAF is not a particularly deadly war. Our deadliest war to date is the American Civil War with 750,000 U.S. military casualties. World War II, 400,000. Vietnam, almost 60,000. We have 7,000 from this combat. But look at the wounded to death ratio. This is new. Military medicine has advanced so much since Vietnam. People survive their wounds, they come home, and they need those wounds treated. We're seeing these ratios here. We have 10 to 1 and 8 to 1. So that's a big number. This leads one to study death after deployment. Mary Bollinger is down in San Antonio. She works with Erin Finley, the woman who has the flu and can't be here, and I used to be down there with them. And we did this study of excess mortality. The excess mortality in VA patients relative to US population is like 3 to 1. And even relative to Department of Defense, it's still 2 to 1. So we have patients who have a great deal of need. We need to make those ratios smaller. We need to make that circle of death smaller. I did do a small study that took advantage of being located in San Antonio, and it was this tracking study looking at transition from the Department of Defense military medical facilities there into the VA. So what we did is we got some data out of the DoD, which is quite a trick, and we took it over into the VA. This was a huge regulatory barrier, even though we were really only just running across town with an encrypted hard drive. So that purple rectangle is Fort Sam, where Brooke Army Medical Center and the U.S. Army Institute of Research are, and the little yellow circle is the Audie Murphy VA, where we were. It turned out that while we were able to do this one-time thing, it wasn't a generalizable transition process. As soon as Mona Bingham retired out of the military, the ability to do this kind of transfer ended. In terms of results, we found that about 25% of these wounded warriors who were discharged from either Brooke Army Medical Center or the USA ISR, which includes the burn unit, about 25% transitioned into VA care in 3 years, within 3 years. And the ones who came, and also the ones who stayed in VA, really came for the mental health care. So you see the high numbers, 81% and whatnot. The reason the burns are so high is the way burns in the military are treated is if you live west of the Mississippi, you go to Brooke Army Medical Center, and if you live east, you go to Walter Reed. Okay. So that was treatment inside the VA or getting into the VA. You notice that a lot of people didn't get to the VA apparently. And Aaron Finley and my partner John Zieber worked with Polly Noel, who's also down in San Antonio, to just do a little study about, well, what's going on in the community. And they surveyed the patients in the waiting room and the providers in about 20 clinics. And it turned out that like half the people reported having a friend or a family member who had been deployed, and they were dealing with that. So a very wide circle of influence, even though there were very few veterans in the waiting room. And the proprietor said that they really didn't feel prepared to work with veterans on war-related trauma. Then more recently, I've been working with Maxine Trent, who's a psychologist at Scott & White. And they had a program that was funded for 5 years, unfortunately, it ran out of funding. And it was located in a clinic right near the Bernie Beck Gate out at Fort Hood, which is about 45 minutes from Scott & White. And it was the Homefront Healthcare Program, and they offered free, unlimited, confidential counseling to active duty and their family members. The confidential part, they did a very clever thing. The people had to be registered in the Scott & White Healthcare medical record, but it was encrypted so that other providers couldn't see what was going on. And the reason that was important was, as you heard before, was to deal with the stigma that, literally nobody could see what you were talking about and why you were there. Certainly not your commanding officers or your buddies or whatever you were worried about. And we found I've just been looking at the data. That's my thing. We found that there was really a tremendous need, not only among the soldiers and their partners, but among their children. So this comes back to what you've been hearing. I do spend a lot of time looking at care equity among VA patients. Some of the things we've looked at include are the differences for Black versus white veterans. And when we looked in 2002, 2005, we found that looking at monitoring the metabolic parameters, the weight, the blood sugar, the cholesterol, was better for whites than for blacks back in that period of time. But by 2009, the care had gotten equivalent, so that was a good news story. Then I have a very big surgery study again, looking at serious mental illness versus not having a mental illness. And this serious mental illness is not just schizophrenia, it includes PTSD and major depression and bipolar disorder. And we found that suicidality was higher for the Black veterans following surgery, which is a surprise because in general, the Blacks have lower rates of suicide than whites. So it's a surprise. That suggests that we may need tailored care post-op. And then we looked at whether obesity care. Now, obesity in the VA is extremely common. We have, I think we're at 60% of overweight or obese patients. Excuse me. And there is a comprehensive nationally rolled out program called MOVE, which is weight management, weight loss. And we wondered, well, are the psychiatric patients who are on these diabetogenic meds, are they getting the care? And yes, that's another good news story. They actually get equal or more higher rates of care for obesity. But then we looked at mortality after vascular surgery, also cardiac. The vascular surgery, I did not know this, it is very dangerous. 20% of patients die within 1 year post-op. But for schizophrenia, it was noticeably higher. It was 24%. Now, when we put in a lot of adjusters for do you have heart disease, do you have high blood pressure, do you have smoking, do you have alcohol use, do you have a long list of problems, essentially that covaried out all of the difference between schizophrenia and non-schizophrenia. So it is all those comorbid illnesses that is a problem for the schizophrenia veterans. And that's pretty much what we're saying all along. You know, you need preventive care. Now, we are also still looking at the younger veterans, and we looked at QT prolongation. This is a kind of an arrhythmia of the heart. So when your heart beats, you know, it has these electrical impulses, and the distance between, you know, the electricity is on, electricity is off, is lettered, sort of P through R, or T, rather. And if it gets elongated, that's bad, because your heart can go into fibrillation, and you could have an arrhythmia so severe that you would die. And there are drugs that increase that elongation. And it turned out that it was sort of you know, like a 20-to-1 increased risk for the veterans who are on antipsychotic medications. So we are still looking at heart disease risk among these veterans. Now that's kind of my overview of my research to date. Virtually everything for me is about the data. What I do is I take the data out of the back end of the electronic medical record system. The VA is treating 5.5 million patients per year. They average 10 outpatient visits a year. They average something like, I think we're up to 12 medications per year. So if you get that filled every month, you know, we're talking about multiplying the number of data points kind of exponentially there. Not to mention when you get a lab test for, you know, let's say you want to look at your cholesterol and your blood sugar, that's 20 tests from one lab test. You might do that 4 times a year. I take all that data and I mush it down into a case-level database so it can be analyzed to answer these kinds of questions. This new project that I'm getting into, and I dragged Aaron Finley into this one, is actually survey data. Of course, I'm not collecting survey data. I'll just deal with the data at the end. But I'm helping with the questionnaire and the methods and how to recruit people. And we'll be surveying 7,500 veterans immediately post-separation from the military and looking at how their well-being unrolls over the next 3 years. And the thing that we're interested in is, well, when you get out of the military, everything changes. You know, you don't have that structure. You don't have your housing. You don't have the job. You don't have the location told, you know, fixed for you. So everything's kind of new and different. And for a certain percentage of people, it's very hard to adjust to that change. And so there's and whether it's difficult or not, there's going to be programs that can help you make those changes. You know, somebody to help you manage your finances, someone to help you find and get a job or keep it, or have a good resume, or look right when you turn up, or cope with family problems. There are a lot of programs, and some are national, some are regional, some are state, and there's grassroots programs to every major city and lots of little tiny towns. have their own programs. The question is, with so many programs, and we're thinking there's more than 60,000 programs to help new veterans. You know, what works? How do you pick? How do you know if you're going to fund a program? You know, what program do you pick so that you're pretty sure it will work or will be helpful? So what we're going to look at is not the individual programs, because that's impossible. We can't look at 60,000 programs, but the components of the programs and try and figure out, you know, what are the building blocks of an effective program to help achieve well-being in veterans. That is my talk for today.
These things out of order. Thank you so much. Come on out here. I just told her I can't believe we haven't gotten these things out of order somehow. Dr. Copeland, thank you very much. Great. And